Well, hello, everybody. Happy Monday. Whoops, that's a nice echo. Let's try that again. Okay, let's try it again. Good morning, everybody. Happy Monday and welcome to our July version of Grand Rounds. We're just about ready to get started. We have a very interesting discussion today, and to get ready, could everybody please make sure that you're muted? We're going to be using, as before, our chat function so that people can bring your questions to the table. And our highly adept chief residents will be here to manage the discussion and manage the questions. So please feel free to add your questions, load them in anytime, and we will save some time at the end to get some questions answered. I know that this will be an interesting discussion. So the title of our Grand Rounds today is Parenting in a Crisis, Parents, Children, Stress, and Schools in the COVID-19 Era. And as we're all sort of watching the impending arrival of September and wondering what in heaven's name we're all going to do, I'm very interested in hearing our speakers today. We're going to start out with our COVID update with Dr. Anna Samuels, who has been so helpful to us presenting these updates at the beginning of our Grand Rounds information. I did ask her to focus a little bit this time on the issues of returning to school and some of the epidemiology and the questions and the answers around whether or not returning to school is reasonable and safe. After Dr. Samuels is finished, we're going to hear from Dr. Yolanda Abel. Dr. Abel is an associate professor and chair of the Department of Advanced Studies in Education at the Johns Hopkins University School of Education. We are very lucky to have her joining us today. She's a faculty affiliate with the Center for Social Organization of Schools and the Center for Safe and Healthy Schools. Her publications have appeared in the American Educational Research Journal, Journal of Negro Education, Education and Urban Society, and School Science and Mathematics Journal. Dr. Abel is currently chair of the Family School Community Partnership Special Interest Group within the American Educational Research Association. Her dissertation was African American father involvement in their child's school-based lives, and it earned the 2008 Judith Ruchkin Research Award from the Maryland Association for Supervision and Curriculum Development. In 2017, Dr. Abel was awarded the inaugural Excellence in Mentorship Award for providing a quality mentoring experience for junior faculty at the School of Education, and was an honorable mention for the 2019 Provost Prize for Faculty Excellence in Diversity. Dr. Abel has a voice for wisdom around education and in complicated school settings. So I'm really looking forward to hear what she has to say. After following Dr. Abel will be Dr. Carissa Parrish, who is Associate Professor of Psychiatry and Behavioral Sciences and co-director of the Pediatric Medical Psychology Program.
Welcome to Zoom. Enter your ID followed by pound.
Oh, somebody needs to mute. Let me try again. Dr. Parrish is the Associate Professor of Psychiatry and Behavioral Science and
Enter your participant ID followed by pound. Otherwise, just press pound to continue. Please enter the missing password followed by pound.
What is that?
The meeting now. There are more than 200 participants in the meeting.
Can somebody please mute?
Maggie, the host can mute everyone.
Yes, we're trying to. Let's try. Manage participants. Mute all.
I got you.
Okay. Okay, ready? No, it says I'm muted. Unmuted. Okay, great. Now we're going to keep going. I'm going to try one more time to introduce Dr. Parrish, who I think is a wonderful faculty member in the Children's Center. So I want to make sure we all know who she is. Dr. Parrish is Associate Professor of Psychiatry and Behavioral Sciences and co-director of the Pediatric Medical Psychology Program and the Division of Child and Adolescent Psychiatry. She is training director of the Postdoctoral Psychology Fellowship Program. Dr. Parrish completed her PhD in clinical child psychology at the University of Maine and then a clinical internship at Stanford before coming to Hopkins as a postdoctoral fellow. Dr. Parrish specializes in improving emotion regulation in children and adolescents. She has established very successful collaborations with physicians to address the psychosocial and emotional sequelae of chronic and acute medical stress in youth and families. Her research program focuses on investigating the development of emotional regulation among youth and how emotion and coping processes are related to psychosocial functioning. So you can see we have a wonderful combination. So I'm going to now yield the floor to Dr. Samuels for our COVID update. Thank you. Yeah.
Okay. Can I say yes to this?
I think yes.
You should be able to just exit out.
Hi, everybody. Happy Monday. It's my pleasure to be with you again today to discuss some of the recent epidemiology, a few literature highlights, and infection control updates. So taking a snapshot at the world view, we are over 14 million cases recognized worldwide, with rising daily cases worldwide and over 600,000 deaths, with the US at the top of that list. In the United States, there is a diversity of cases throughout different areas. The states with the highest number of new cases recently include Florida, Texas, California, Georgia, Arizona, and then others. We in Maryland are towards the bottom of that list, fortunately at this time. Also looking at the rate of growth of new cases across the different United States, Maryland is at 0.9%, still in the positive, and in red, meaning it's getting higher. The top of the list here is they're in order from one onwards at the fastest growth, really in the west and south regions. In Maryland, we are seeing a rise in new cases identified in the last week or two. We saw a nadir in mid-June and subsequent slow and steady but sure rise. This is now being coupled with a slow rise in the number of hospital beds occupied in Maryland. And this is from the maryland.gov coronavirus website. The positive testing rate is about 4.5% at the state of Maryland level. Looking at the Johns Hopkins medicine entities, we're testing about 1,400 samples a day, so our volume is continued to rise. And you can see there's a slight uptick in the percent positive, which is the bottom red and orange line. Looking at where patients are coming from who are cared for at the Johns Hopkins entities, they're primarily in the Baltimore, DC corridor. The highest zip code remains 21224 around Bayview, and also includes the Dundalk area, as well as some parts of Baltimore City, and Columbia has the next highest number of cases. As of last night, we had 31 patients admitted at Hopkins Hospital, 96 across the entities. There were 5 ventilated here, 10 across the entities, and last night there were 2 pediatric patients admitted within the Children's Center here. In terms of keeping tabs on the MASC diagnoses, we've had 11 patients meet the CDC case definition and reported as such. We've also reported 4 additional patients who didn't quite meet the CDC case definition because of the negative COVID testing, but otherwise met the syndromic definition, for a total of 15 reported cases so far. And interestingly, we've had no new cases present in the past 3 weeks, which I do believe coincides with that nadir of COVID cases in the state of Maryland in mid-June. So unfortunately, I think we are expecting, as the Maryland cases rise, we will again see some MISC cases, but we are happy at this time to have no new cases. So some literature mentions. This study was published in Nature Medicine, and I'm pointing it out because it got a fair amount of press and it raised a lot of important questions, as most studies seem to do, rather than answer them. However, what this group did was compare 37 asymptomatic and 37 symptomatic patients diagnosed with COVID in China. And they looked at their immune response at roughly 4 and roughly 8 weeks into detection. And so the summary of their findings is that the immune response seems to be more mild or weaker among patients with asymptomatic infections, and the antibodies wane with time, either both with asymptomatic and symptomatic infections, but more so if among those with asymptomatic infections. So, for example, 93% of patients had IgG antibodies at 4 weeks, and this declined to 60% for those with asymptomatic infection at 8 weeks. And that was compared to 97% among those with a symptomatic infection, which also declined, but down to 87% at the 8-week mark. The asymptomatic patients shed virus a little bit longer, 19 days as compared to 14 days in the nasopharynx, and they also had a lower cytokine profile, all supporting a general more mild immune response to infection. And so this does raise questions both for vaccine efficacy efforts. If people do not have a symptomatic infection, will that therefore hinder their potential for immune response? It's also interesting whether these patients could get reinfected perhaps, or if there's other parts of the immune system that might have a memory, for example, a T-cell response that we're not measuring in these types of studies. So I'm bringing this up, and feel free to read this more in depth. Now I'm going to transition to another idea, and this is going into today's topic as well, I think, about how does this COVID pandemic impact our return to school? Recently, the AAP put out a statement, and I'll quote that statement, that they strongly advocate that all policy considerations for the coming school year should start with a goal of having students physically present in school. Now, this is with children and students in mind. And there's lots of considerations across the board with this ultimate goal of having students back in the classroom. So what literature exists that might inform the safety of this? And there's 2 studies in larger, more prominent journals that kind of touch on this topic published in the last month. So one is in CID, and they essentially looked at 3 isolated exposure scenarios where a child or there was exposures in a child setting. So one was a 5-year-old diagnosed with COVID who went to preschool. Another one was a 12-year-old who went to school. And then the third one was actually an adult teacher who went to a preschool or was working at a preschool. There was several people who became symptomatic, but no one that they tested was positive for the coronavirus. And so this study, these authors suggested that perhaps transmission in these younger age group settings might be lower. Now, of course, there's a lot of questions there. What was the timing of the testing? Was it false negative, for example, et cetera? And there's a lot of other questions. However, this is one study that is early, I think, in the development of this literature. Another study was published in Nature Medicine, and they tried to look at the susceptibility to infection across the age range. And their conclusions were that symptoms manifest in about 20% of 10 to 19-year-olds, and this rises in age groups to about 70% among people infected who are greater than 70 years. So basically, as you get older, you are more likely to develop symptoms and exhibit illness. They also looked at the susceptibility of infections at general cutoffs, and they found that the susceptibility to infection of people less than 20 is about half of those adults as compared to adults greater than 20 years. And this data came from several countries around the world. And generally, our epidemiology in the United States would support this type of finding, that we do have fewer patients recognized to have COVID who are less than 20 years as compared to those in older age groups. But this doesn't necessarily address, are these younger people who are infected able to transmit the virus to others? And so I think we should assume that yes, for now they are. So thinking about all of these considerations about back to school, Dr. Sharfstein from Johns Hopkins and Dr. Morphew tried to synthesize some of these considerations in an article in JAMA, and I'd like to kind of summarize some of their thoughts. So there's a lot of benefits to reopening schools. We want to optimize children's education. It equalizes access to materials, especially for people who don't have computers and ready internet access. Online learning might really be quite inferior otherwise. It offers nutrition and meals to those who wouldn't otherwise necessarily have access to that food. It also opens the door to access to health services, reinforces vaccinations. It helps avoid and reduce and recognize children who might be neglected or abused. And it also helps accommodate parents who are working and need someone to help care for their children and teach them when they need to be working. Of course, this comes with risks. Though children might be less likely to get infected and sick from infection, children still do get sick, and some of them may get very sick. Some may develop MASC and become critically ill, and we have had deaths as a result. We also know that bringing people together will increase the risk of transmission, particularly among adults. Even if children have a lower risk, there's still going to be the adults, the teachers, the professionals, and then all of these people's respective households. There's also a risk of unforeseen closures. Let's say schools open up and then there's an outbreak or the cases rise and then they have to reclose, and this causes disruption. And that necessitates backup scenarios for all the situations. So there's many challenges. How do you physically distance students? How do you cohort students and teachers? For example, keeping a teacher with a class rather than a teacher with 8 different classes. How do you get students to and from school safely, as buses might otherwise overcrowd children together? How do you limit contact with other people to reduce the networks? How do you enforce hygiene and mask wearing? What about people with individual risks? Some patients and students and teachers will have conditions for which they are at higher risk for complications. And there's also people who just have a different risk tolerance and they won't wish to participate even if it's available. And so this requires a tremendous amount of flexibility. And this flexibility does require a lot of resources. And so this is probably the biggest challenge, looking into what might work for different settings, and there's unlikely to be a one-size-fits-all. I'm gonna skim this now. Peds clinical articles have mentioned there's an MASC summary in the New England Journal for which we did contribute some cases, thank you. And there's a COVID-19 cohort description in Pediatrics recently published about children admitted with COVID. Some basic COVID updates. One thing that has come up and raised a lot of questions recently is our governor has supported testing of all persons who wish to have a test. However, we don't actually have the capacity to test anyone who wishes to have a test. So we do have limitations in testing the staff, the sites, the supplies, even though we are doing a ton of tests. So please consider our Johns Hopkins guidelines for testing, either testing patients with symptoms for COVID or those who fit one of the asymptomatic protocols for pre-procedure or admission screening. And if patients are requesting asymptomatic testing outside of our guidelines, there is available testing throughout Maryland. This is the website to inquire on testing sites. Some sites require an order and you can order through CRISP. And so I offer these websites here to get that information. Lastly, assume everyone is infected. Wear your mask, keep your distance. All encounters, you need your mask and your eye shield. And if you're doing an aerosol or high-risk intervention, you need your respirator, eye shield, gown, and gloves. And I will close every talk with that. So assume everyone is infected. I hope everyone stays healthy. It's my pleasure to speak with you, and we look forward to again in August.
Thank you so much, Anna. Now we're going to go on to Dr. Abel. Dr. Abel, can you share your slides, please? Welcome again. Wait, did we stop sharing? Wait, we have to stop sharing. Okay. Okay, there we go. Now, Dr. Abel, can you share your slides? I think you might be muted.
I should be unmuted.
There you are. All right, welcome.
Good afternoon. Thank you for having me join you this afternoon. This is a topic that is on the minds of many, obviously. A lot of the information that you just received in your update are the types of things that school district personnel are considering around do they or do they not open schools? Do they do it in the traditional way where everyone comes in some form of hybrid? Are they totally online? The adults who work in those schools as teachers, secretaries, housekeeping, so on and so forth, are also worried and stressed about whether or not schools go back and what that means for their own health and well-being. Again, much as what you just saw, it isn't necessarily that children are experiencing COVID in high numbers, but children cannot be in schools without adults. So what you see in front of you is a school family community partnership model. And it is basically thinking about school-based personnel and students' families. However, I chose to share this today because I think you as medical professionals could also have a model like this in so much of how you are working with students and families in terms of the patients that you are seeing and what type of information and resources that you have available to share with them. In the context of educators and schools, this model talks about the challenges that are quite often experienced, and to some extent that comes back to the resources portion. Again, that was just shared in regards to what do schools have access. Last academic year, lots of public schools had to go online virtually overnight. They all did not necessarily have the bandwidth in terms of one-to-one devices, in terms of teachers who were comfortable and confident in doing lessons online. So kind of how do we make those types of things work? There are both organizational and process conditions that work towards that. And these are the 4 C's, which I'm going to skip right now and come back to on the next slide, with the thought process that both educators and families come out of this empowered to better work together in ways that support student learning and overall outcome. So again, in lieu of the educators, I think we can put the medical professionals there. And if we move on to my next slide, where we can just focus on the 4 C's, their capabilities, connections, cognition, and confidence. So Mapp and Bergman, for this iteration of this dual capacity model, look at capabilities as skills and knowledge. So what is it we know and what do we know to do with it? Connections, our networks, who is in this process with us? How can we be helpful to one another? Cognition, shifts in beliefs and values, not necessarily a part of this conversation, but over the years, as I'm sure most of you are aware, there has been a movement around anti-vaccinations to some extent. So if we are having those kinds of conversations with people, we are looking potentially for people who might be part of the protocol if and when we get a COVID vaccine to test. Flu season will be coming back among us. Do we not get a flu shot? Kind of what might be some of the work and the thinking that we might need to do with students and or their family members around those types of issues. And last but not least, confidence refers to self-efficacy in regards to your belief about your ability to do. I obviously do not know those of you who are on this call. So on some levels, it is hard to structure, so what do you do? Because I don't know what some of you are already doing. So in so much, there are 3 generic questions on this slide that ideally when we have time to have conversation at the end, some of this will come back and we'll do some of that exploration. But what are you currently doing that connects with students, their families, or schools? So in your office, on your website, however you are sharing information with families and children, your patients, how have you extended that into the realm of COVID? What are the considerations around self-identification and knowing whether or not you need to be tested or your child should be tested, especially in light of that there's only so many tests to go around? What do you know or what do you share with families and their children around when to make the decision to stay at home and self-quarantine? What kind of guidelines are given for those individuals such as myself who live in Baltimore City and in the row house in fairly close quarters and somewhat small, depending on, how many people are in your family, how do you manage and mitigate those types of things? My next question, what is feasible for you and your office to do that supports students, their families, and schools during this time of a national pandemic and a concentrated effort on systemic inequality in the United States? I know this talk is around COVID, but again, living in the United States these past few months, there's been a lot of things on the news. Some of that also being around how racism is a contributing factor to the large percentages of individuals identified as African American who might have been experiencing COVID. So kind of the stress associated with that. What are some of the tips, suggestions, techniques? And it might not even necessarily be for the person who is coming to you either as an adult patient or who is bringing your child. But I'm originally from New York City. I still have family in New York. And when New York was kind of the epicenter of COVID, there was a level of stress just worrying about my family members, especially those who still need to go to work. I have some who work for the Mass Transit Association. You're around people, you're in the public. So while we have these minimizing activities such as social distancing, 6 feet, wearing a mask, there's still that level of stress and worry that occurs. My last question, how are you and your colleagues coping with stress related to COVID-19? Those who are parents and those who are caring for elder family members. One of my closest friends is a nurse in Atlanta. So, Georgia is also one of those hotbed areas around COVID. So in the context of doing this work, being committed to it, how are you managing your own stress? In so much that it is hard to give to others if you're not giving to yourself. If you also have children and you're having your own level of stress around whether or not their schools will be back face-to-face and in present, or if they're staying home, what does that mean for your schedule, your ability to cope? Recognizing that there may be some SES implications that have resources that might make that a slightly easier transition than that low-income family might have and or experience. There's still some level of stress there. What types of things are helpful and useful to you? How might that play out to, again, your patient base, either the adult patient or the parent bringing in their child? Again, for that same category, for those individuals who have elder family members, Hopkins, I work at the School of Ed, and for the most part, we will be online this fall, which I appreciate. My father, who's in his 70s and has an underlying condition, now lives with me, so I do my best to minimize how often I go out in hopes that I don't bring something back into the home that might contribute to him getting COVID, because again, the risk is higher. So those are like my 3 broad questions that I'm asking you to consider and that I hope once again we have some conversation about as we move on. So thinking about those potential actions, I talked about that a little in the context of what I was just saying in regards to those big questions, but being a tad more explicit, again, the conversation around racism and structural inequalities, healthcare, things of that nature, how they might be impacting the African-American, Latino, and or low-income community. There's a medical student from the UK who created a handbook of clinical signs for Black and brown skin. If you haven't seen that news article yet, it is hyperlinked. I'm not going to bring it up. Information about testing. Are there places and concerns that you should go? At the School of Education, I'm part of the Critical Incidents Command team. And so we've been talking about what do we encourage students, faculty, and staff to do if they think they need testing? How does that information get shared with employers or not? There's some HIPAA stuff in there, as all of you well know, but how does the employment place then kind of balance that out with making sure it's doing what it can to keep as many people healthy in this context of this pandemic? Information about living with others in fairly small spaces, preventing COVID or someone has COVID. I had a friend of a friend that she was caring for her husband who had recently had surgery. And in the process of caring for him, she was diagnosed with COVID herself. So kind of how do we balance these things out? Information about stress and suggestions for self-care, some of which I think you will hear more detail about from our next speaker, Dr. Parrish. But again, just kind of that normal balancing out. even for those of us who might be working at home in an effort to kind of minimize contact, so on and so forth, the stress of working at home. How do you find time to still make sure that you are being well-rounded? One of the best suggestions that I received from a colleague was to use my commute time as my exercise time, since I'm not in the car driving to and from the workplace. So what might be ideas and suggestions? The list has been up here for a bit, so I'm not going to go through the whole. I wanted to talk a little bit about, again, not knowing what you're already doing. Is there somebody in your office? Is there an organization that you get your informational supplies from, your links to your website? How are you doing your best to kind of stay up to date and current with the types of information and what might be going on? I know Baltimore City Schools just made the announcement today that it will be virtual in the fall. There's some other school districts who are making that decision, some who are still saying face-to-face, so that you can kind of target the suggestions and the ideas that you might be sharing with the adults who come through your respective practices. I always like to say thank you whenever I do a talk. And last but not least, this is my email if someone would like to reach out to me personally for whatever reason at a later date. Thank you.
So much, Dr. Abel. I appreciate your comments very much. And I think that they have generated some good questions already. And we will look forward to a few minutes to have some discussion around those questions. So right now I'd like to ask you to stop sharing and we'll go ahead and go to Dr. Parrish. Dr. Parrish, are you sharing?
I am here. I'm trying to find my PowerPoint after getting it all ready.
I know you've had a busy morning.
There we go. Does that look okay? Is it showing up? Okay. So I won't go through. Can you see it now? Is it okay? Okay.
Yes.
I'm not going to go through each one of these things that I've listed here, but I wanted to provide a context for sort of shifting to mental health considerations for families during COVID-19. I've had a lot of conversations with people in my neighborhood and people interviewing for different stories. And I tried to highlight some of the things that are in my mind as I'm supporting parents and kids in my role as a child psychologist here at Hopkins. The containment strategies, but also as we're all seeking to do the best job that we can by patients and also our colleagues, the constant shift of trying to keep up with those best practices while also maintaining some semblance of routine in our family life is contributing to kind of a melting pot of multiple stressors. There have been several articles, and I'll show some data that we're collecting here at Hopkins describing disruptions in family routines. And even though I often think about my children's time in their preschool with their teachers about how important the routine was for little people, it's obviously very important for our teenagers, young adults, each other as well. So disruptions to school and childcare through closures, decreased physical activities for a number of reasons, and as well as the increased screen time with remote learning, but also needing virtual babysitters, shall we say, when folks are juggling work-life demands, contribute to a lot of potential problems that we probably have yet to see the full impact of. Decreased physical activities are linked to poorer sleep in kids, and increased sleep time, or increased screen time rather, exacerbate sleep problems as well. There have been a few articles, and I provided a link here to the Sleep Foundation, that increased anxiety, increased sleep disruptions can intersect to increase an individual's risk for suicidal thoughts and consideration. So one of the things I'm hoping we can kind of highlight during this mental health portion too is as providers of different kinds, whether it's educational, medical, psychological providers, there are certain things that we want to kind of keep on the radar for screening both with parents and with kids as we go into another phase of sustained remote activity. So I'm sure everyone has seen this article, and if you haven't, it's worth a read. In the COVID-19 economy, you can have a kid or a job. You can't have both. I know there's a lot of struggle in thinking about the sustained engagement via remote learning, and I share that concern. And one of the things that I'm thinking of too is how to help parents calibrate our expectations, both for our employment and family responsibilities, but also child care and educational responsibilities as parents. Some of this is going to kind of yet to be determined how we can calibrate it the best, but that is something that I keep coming back to in my work, is how we can continue to use data that is available to us as parents, as educators, as healthcare professionals to support families and continuing to calibrate that as much as possible. That having been said, it's not a stress-free proposition. So the American Psychological Association has been conducting Stress in America surveys for several years now. And I pulled the data from the last two that have been published. So this first one, the kind of stress level of parents versus other adults, non-parents. So in previous years, the rating, I think it was a year ago, the rating was in the high fours, like 4.9, something like that. So definitely there's been a bump that is detectable in this pulse survey through the APA, and that it is higher for parents of kids younger than 18. And you can see here on the second data available from APA that parents are worried about the long-term consequences of the pandemic on their child's development. Not only educational, which we're clearly all very concerned about, but also social development as well. I was fortunate to find this data as well. So something that is lagging compared to the medical information in our fantastic journals like the Lancet and New England Journal is having more detailed information about behavioral or psychological changes within families and kids. So there was a survey, the lead author of the group is a parent research group at University of Michigan. They used the standardized screeners that I know that we also use at Hopkins, the PHQ, and then the GAD, the Generalized Anxiety Measure. So this was administered remotely to parents online at the end of March. 50% endorsed anxiety symptoms at nearly every day or several days a week. 40% scored at an elevated range on this PHQ-8, and then 39% were elevated on the GAD-7. So a substantial proportion of parents currently are endorsing elevated levels of both anxiety and depression. Their team also looked at parent-reported anxiety symptoms as well, and parent anxiety and parent stress was correlated with higher levels of parent-reported anxiety. And then a substantial proportion also were reporting increased alcohol or other substance use as a coping strategy. And even without endorsing it as a coping strategy, 22% endorsed increased alcohol use. As you can see, we can quantify this, the types of worries that parents are reporting in a number of ways. There's a lot of financial employment challenges. 50% of parents in this survey reported worries about being able to pay their bills. And I know that there are a lot of efforts underway throughout Baltimore City about potential strategies for supporting very vulnerable families. And you know, we're very grateful to our social work colleagues for continuing to explore the options that exist to support our vulnerable families. 55% of parents reported a fear that their money will run out. So within these studies, there were a handful of self-report variables, and then kind of like looking at how these variables might map together. And so families that were reporting a job change in the prior few weeks, that change in their employment was associated with an increased risk of physical discipline, including spanking or slapping their child by self-report. 50% also reported social isolation concerns and parents' perception that they were isolated, which may be different than actually having a lack of social support, is that perception that I have support, that was associated with increased verbal arguments toward their child, but not physical discipline. So there may be kind of complicated relationships between different types of worries and concerns and how that manifests in specific parenting behaviors that we can, as child providers, can be sensitive to. So on this survey, there were the ratings of parent stress on this 0 to 10 Likert scale, and 46% of parents were endorsing a stress level that was at the highest end of that scale, compared to 28% of adults without kids. So we know that there's extra burdens on individuals caring for kids, and us as pediatric providers being kind of well poised to help discern what those are and link to appropriate services. Finally, thinking about this announcement today for a lot of Maryland schools, Baltimore City and Baltimore County included, now preparing for virtual remote learning, is that parent depression symptoms and parent stress decrease parents' kind of self-efficacy for engaging in this additional task that is yet so important. Finally, the data did include specific parenting behaviors directed towards their kids, and you can see 61% endorsed verbal aggression, yelling, screaming, shouting towards their kids in the past 2 weeks. And this was data that they obtained right at the very beginning of the kind of widespread quarantining. 20% reported spanking or slapping their child once in the last 2 weeks. I have, when we get kind of past, I'm going to show some data that our colleagues here at Hopkins are collecting. I'm going to link to some specific strategies and handouts that are available in, I think it's 50 languages, that can go through some basic things that we can give to parents for free. Most people have smartphones. We can share these things with families as well. And so I'll show you the links to those too. So here at Hopkins, we have a couple of data sources that I just wanted to highlight to contextualize this for our institution. So the first set of data comes from parent-reported family stress of COVID, the impact of COVID on family functioning. And this is data that my co-director of our pediatric psychology program, Liz Reynolds, has been collecting on our inpatient unit. And it's a scale that was created by one of our colleagues who specializes in traumatic stress at Hopkins and Kennedy Krieger, Dr. Kaufman. And then the second set of data comes from our pediatric surgery colleagues related to traumatic injuries caused by child physical abuse. So I appreciate Dr. Nasr and Mark Kovler providing that data to me. So we'll start with the inpatient data real quick. So this is data that we gathered during children's psychiatric inpatient hospitalization, and this COVID impact scale has, you can see here how these things are scored. So it has an example for each one, like COVID has impacted my family in terms of how we handle our routines, including work, education, social life, etc. And then the parents rate how much of an impact COVID has had on their family. So this is about 40, you can see here, 47 parents' reports since April 29th is when the measure started being administered on our inpatient unit on 12 South. And you can see that there's a lot of things that we have on this scale, but the only thing that showed significant elevation was the routines variable. So you can see that out of a possible 0 to 2, or 0 to 3 rather, we'll see, 1 to 3, that the routines were significantly elevated compared to these other domains of employment, food, medical access, and so on. Now, obviously, this is a small sample, and it's highly specific to our psychiatric inpatient unit, but you can also think of our child psychiatric inpatient unit, too, as kind of a pinnacle of what happens when families experience significant stress. The second data that I wanted to share comes from the Pediatric Trauma Registry. Mark Kovler is one of our, I think he's maybe in his fellowship here now, was a surgical resident, collected data from the registry looking at kids who had a traumatic injury that was caused by child physical abuse. So the survey period was around mid-March to the end of April. And then they pulled data for those same time periods from 2019 and 2018. So you can see that there were significantly greater proportion of total trauma patients during our pandemic quarantine time, where kids were coming to the hospital because of physical abuse resulting in traumatic injuries, compared to the 2 years prior during the same time frame. And so thinking about kind of these public health decisions and the role of school and reopening and virtual considerations, this is one of the data that we're sort of fearful of, is what happens when there is kind of a pressure cooker around a family, and how can we prevent the worst possible outcome related to kids during this time. So things for us to consider related to child maltreatment risk: child care unavailability, whether that's due to a lack of babysitters, daycare facilities, or having to choose between watching a child and going to work, that kind of pinch for working parents. The reduced access to resources or being able to even maintain kind of predictable routines can be a risk factor. The lack of systematic resources obviously can increase family stress, and that has been shown in other pandemic situations to increase risk for physical abuse and domestic violence. The reduced surveillance by mandated reporters in school is school teachers and school counselors, nurses, et cetera, are a big source of identifying potential cases. And even in cases where there's not physical abuse, but more neglect situations, schools are often the front line for identifying those cases. So coming up with other solutions in conjunction with our school colleagues will be another place for us to support kids' development during this time with more advocacy. And finally, related to that, there's a need for increased social support delivery. There's a few articles that I found that were talking about kind of the social services version of our redeployment effort. So there may not be the same type of work that our social services colleagues in the city may be able to do, and maybe there may be a way to pivot those resources in a preventative sense. This is a table that I pulled from an article. Charles Zena was the senior author, describing what clinicians can do to try to mitigate risk for family violence during COVID-19. So I have 2 slides here. I won't read every line. I apologize, it's so wordy, but I thought that the suggestions were so good that I wanted to just highlight them. So the first set is recommendations for clinicians and how we can continue to be sensitive to the risks and in some cases the disproportionate kind of risk faced by families during the pandemic. So continuing to make violence a potential part of every assessment, being sensitive to each family's individual risks. And especially those of us in pediatrics, obviously we have long-term relationships, hopefully, with families as well. And so we may be more aware of individual risk factors and how those may coalesce with a particular family under these considerations. Checking for those risk factors I mentioned, so access to resources, which may include food security, other social services that have been previously accessed by the family, and making sure that they can continue to access that. For families with mental health challenges, helping families stay connected to their mental health resources. And then social supports available to the family and how they can make use of those despite the pandemic social distancing, physical distancing recommendations. And this, at the very end, identify families who are more at risk for these violence and other physical discipline or other negative outcomes based on our own knowledge of the family. Separately, as clinicians, these are the second table from that same article by Charles Zena, recommendations that we can make to parents. So obviously all of us are at risk for potential stress. I didn't spend as much time today talking about the risk for essential healthcare workers, but we know that folks in our positions are also at risk for elevated stress too. And recognizing that all of the feelings of stress, whether it's anger, irritability, worry, etc., they're expected. And how do we calibrate knowing that everybody's kind of swimming in different flavors of the same really stressful situation? Routines is something, as I mentioned, we found in our data, but also highlighted in other published data as well, and how to help families not be prisoners of a really tight schedule, but how can we use routines to promote family harmony and family emotional well-being during this really challenging time? How do we have kind of a safety plan when families need a break? And I have some nice handouts that UNICEF has prepared that kind of go into this as well. And then for those of us that can do assessments using evidence-based resources to screen for stress, depression, and anxiety in kids and parents when appropriate. So just wanted to highlight these. So UNICEF has made a lot of materials available. Initially, when the pandemic was first emerging, there were 5 basic positive parenting handouts, which were so beautiful. I'm going to show just a couple of examples. And they were translated into some 50-something languages. And so clicking on these, you'll get to see these beautiful graphics, very simplified language, and then evidence-based approaches to child development, managing stress, managing misbehavior, and so on. Over the course of time, as more risk factors and kind of like hotspots have been identified, UNICEF has kept up with this and has developed additional PDFs. So it's 15, which is a lot, but thinking about like meeting the family where they are, they may not need all 15, but there could be specific ones that are now available already in someone's native language that we can share with families. So this is just a sample of what they look like. It's the first one that came out, so doing the 101 special time. And I just wanted to show it as an example. So they're all very colorful. They have ideas for different age groups. So you can see ideas for little babies and toddlers, for younger kids, ideas for teenagers. And it has basic suggestions about how to do each one of these things. The structure of routines, how do we create a flexible routine without that creating more stress from failure to meet overly high expectations, and also trying to do it with a mind for how do we do this to moderate stress and hopefully increase positivity within the family relationship. One of the things I didn't mention on the slide, I don't want to overwhelm all of us with a bunch of percentages, but the majority of parents, despite all of these stresses, despite all the worries and concerns, something like 80% of parents report appreciating the increased time that they're having with their kids. And kids, you know, depending on the child, have more or less understanding exactly what's going on. And so how's there a way for us to keep this positivity during this time too? There are several resources by the UNICEF, presentations looking at parent stress and child stress, managing negative behavior, promoting coping with different emotions. And finally, one of the points that Dr. Abel had mentioned, that different communities may have more or less freedom of movement for a number of reasons. And so there's more UNICEF support guidelines around, for example, parenting in a crowded home or parenting in a community where just sending your child outside to play may not be as feasible in another community. So I just wanted to put those out. So instead of reinventing the wheel, and there's 400 million websites, UNICEF has something that is evidence-based. It's very positively focused, and it's available in multiple languages. So the usefulness, it seems high to me. So I hope that people will take time to go through those and use them. I wanted to just highlight quickly our resources at Hopkins. And I'll leave that up. Please feel free to, if you want to take a screenshot, or you can always email me afterwards. So we have 4 mental health clinics dedicated to kids. Within our group, we have a couple of things that are specifically geared towards kids of Hopkins staff. So feel free to reach out with questions about that. For employees of the healthcare system, if you're looking for your own mental health care needs, you can contact the psychiatry department at the psych1@jhmi.edu email. If you are a Hopkins employee and you're looking for resources for your child, you can email our JH staff kids at jh.edu. Either me or someone from our child psychology group will reach out to facilitate finding resources or therapy, whatever we need to support you during this time. I continue to be mindful that the stress for this situation is far from over, and we want to be available to support our coworkers as much as possible. We have a wonderful psychosocial group here in the Children's Center, multidisciplinary. We have lots of resources that Child Life has uploaded to the Hopkins webpage. And so you can see there's lots of things here, how to talk about COVID, how to access resources related to COVID. So just a kudos, thank you to my colleagues who've been working so hard on that. The last thing I have here to share is that we're trying to provide as much stress relief as we can, or stress management, maybe that's a better word for it, to our coworkers. And so my colleague, adult psychologist Netta Gould, has been doing daily mindfulness meditation sessions. And I provided the Zoom link here every day, once a day. And then I have been doing a mindful parenting. Sometimes it's mindfulness, sometimes it's behavior management or emotion coaching or self-compassion. So we're trying to target different things. So how do I as an adult cope with things using meditation from Netta, or how do I take those same kind of ideas from a range of traditions and apply that to parenting to hopefully kind of moderate that stress. And that's the Zoom link and the password for mine as well. I'll leave my mindfulness definition there for just a second, but there's been a few websites and folks that are kind of talking about how we can use this as an opportunity to try to center ourselves in between these stressful moments and kind of keep our energy levels optimized. Thank you so much.
All right. Oh. Sorry about that. We've got multiple laptops competing. There are a few questions that have come in through the chat box. So just to get started with a couple, any suggestions for speaking to families about returning on-site for therapeutic services if telehealth is not extended past 7/25? Apparently, most of this providers are concerned about being on-site in a small office.
So we're hoping at this point that the extension that has been kind of hinted at or tweeted about, that it is going to continue. All of the mental health services through the Department of Psychiatry, we meet regularly to make sure that our practices in providing mental health services are matching the recommendations that the rest of our medical colleagues are employing. And so, you know, when you're talking to families or parents, we're trying very hard to maintain that same level of safety and precaution as available throughout the hospital.
Awesome, thank you. Next question, are the mindfulness sessions open to non-Hopkins employees and staff? I don't know the answer to that. I'm not sure if you might.
That is a great question. So for right now, we've been focused on doing these live with our Hopkins colleagues, but I have been trying very hard with our media relations friends to upload the sessions afterwards so that people outside of Hopkins can access those without needing the Zoom link.
Thank you. One of our participants says, I've been wondering about how children will remember this time and thinking that parents have the opportunity to frame these memories to include reflections on positive coping and resilience. Do you know of any resources that promote helping children build a more positive narrative? Oh gosh, sorry, my computer froze. I can't finish. There we go, about the pandemic, sorry.
I can't think of a specific resource about how to frame it, but I think there are really great resources through the growth mindset kind of work, which has been applied in a number of areas. So how do we frame challenging moments or unexpected adversity as ways for us to grow? I think that's one positive thing. I would also say when families are meeting with any of us, you know, as part of their regular care, that we can talk about this as something that it builds communities. It's given us an opportunity to get to know people that we wouldn't have otherwise known. Obviously, this can sound like very Pollyanna-ish, but talking about the unexpected good things. Like I've had many families that have had to travel 2 hours to come to Hopkins for their care. And because of this, we've now catalyzed being able to use telehealth resources in a way that probably would have taken a long time.
I agree. I can't think of specific resources, but as you talk to families and ask to some extent about traditions, policies, those routines, what types of pictures are we drawing? Are we journaling? Are we writing letters? Who are we choosing to maybe talk to virtually? All those kinds of things in the sense of what are the positives and the things that we have to be thankful for? What are the ways that we have tried to make something good and positive and new out of what might not have been our first choice in terms of how some of these outcomes and events are unfolding?
Awesome. And a couple of reminders that have come up in the chat. Somebody made mention that Hopkins faculty have access to the premium subscription to the Calm app. And there's a link here in the chat box for anyone interested. Let me see if I've missed any other questions, and feel free to send any more in. Oh yes, here's a one from Dr. Moon. If schools stay closed, how are we to identify children who are suffering abuse at home?
I think Dr. Moon is asking a really important question that we don't fully know the answer to yet. We don't know, as far as I know, exactly how schools will be virtually connected to teachers during remote learning in the fall. One of the things I think about that I've been trying to do with our patients is trying to keep them connected to their routines of seeing their pediatrician or seeing us in the mental health setting remotely, and then looking for changes or asking questions, kind of looking at the kind of recommendations for clinicians that we can consider. So how has behavior been and other risk factors for kids? So either upset stomachs or sleeping problems or problems with following directions, things that we might think that if they were to continue to escalate, that they could lead to more physical interaction between parents and kids, to try to prevent that.
And most schools will still have some form of physical touch point, much like when schools went online this past school year. We still gave out meals. Leadership team still did home visits, both to check and see who had one-on-one devices, internet access, kind of overall well-being. So while it won't quite be the same as being in school and having that degree of everyday access, if you will, there are still touch points that will happen, even if school is virtual this fall.
Yeah, I think so. Awesome. Thank you so much. Do you want to come to this one, Dr. Moon? Do you want to come to this one?
Thank you so much for a great Grand Rounds. This is Tina Cheng. I just wanted to thank our speakers, but also to tell you about our next 2 Grand Rounds. We will not have a Grand Rounds next week, but August 3rd, we will be starting our health equity series, and we'll have an introduction to implicit bias and invite you to come and hear our speaker, Cherie Wilson. On August 17th, we are going to be having a brief COVID update like today from Anna Samuels, and then we'll be having a panel discussion on innovations to ensure health equity with Alistair Martin from Harvard and Kathleen Page from Johns Hopkins. And we'll be sending out the schedule for the rest of the Grand Rounds for the coming months. So thank you so much.
And we're asking everybody to try and do some implicit association testing through the Harvard app before those Grand Rounds. And I think there's been links in our announcements and also in our weekly updates. Thanks, everybody. This was a really wonderful discussion.